Hi, everyone. I'm Dr. Jay Neugarten. It certainly is a pleasure to be with you here today at this amazing experience and really amazing technological digital, what I consider revolution, where we're really going to be having an opportunity to utilize what I perceive as the next generation in technology that's going to be impacting implant dentistry. Where over years, implants have kind of revolutionized the restoration of dental health, and they've given people confidence in that place to be able to replace teeth. And a dental implant purely replaces the root of a tooth, and then a crown goes on that implant, and whether a crown goes on an implant or a crown goes on a dental implant, it's a crown. But the way that we deliver the care has gotten better for us, where over the years, through the 70s, the 80s, the 90s, and even into the early 2000s, things, and even today, people place it freehand, where you have a drill and you go ahead and place that implant in freehand based upon your skill, based upon your want, will, desire, but also where you want the teeth to be. So through time and technology, that freehand has kind of transcended into the world of guides, which are, let's say, plastic or metal guides. And then ultimately, there's something called augmented freehand, which would be not really haptic guidance, but is more utilizing infrared and cameras to be able to see where you're going to be. And then comes about a company called Neosis, which developed the Yomi, which kind of became innovative and a technological solution for us through the late 2015 and beyond. I became involved in the company and utilizing this technology in 2020 when the FDA approved what we call full arch solutions. So this is something that's been a mainstay of therapy for my patients since 2020 with me. And what we're going to do today is take a patient who lost a tooth about a few months ago. Back in September, our patient's name is Alex. Alex had succumbed to a decay after having a root canal and a crown, and ultimately the tooth became hopeless and non-salvageable. I took the tooth out and we did site preservation with a bone graft. So today, we're now going to return to the site and place a dental implant. And as I've said earlier, there's really 4 ways you can place a dental implant: freehand, or you can use guides, or you can use really augmented freehand, or haptic guidance. And I equate haptic guidance, which is what's called the Yomi today, as almost being, it's me placing it with my hands. And I equate it to being on a train, where you're on a train car, and you're on a track. So what will happen is I will digitally place the implant in the bone to where the dentist that makes the crown will want it, in a relationship of optimal bone position to where we want the crown. And that digital plan becomes synergistic and married to this device. It's a tool that allows me to stay on point and get me into that exact spot where that digital plan is represented. So it's basically managing space. And the space that I'm managing is where this implant is going to go within the jaw to optimize the prosthetic position or the teeth position that the dentist will make. And what the Yomi affords me is accuracy, predictability, reproducibility, and really staying away from critical structures such as the sinus and nerves. And also, not only that, I can really be what we call minimally invasive, where the surgical site can be a lot less exposed. In the world of freehand or in the world of guides, we need to make larger flaps. And with larger flaps comes more swelling, more pain, a longer recovery. When I can make a smaller flap, smaller design, smaller everything, the recovery is a lot quicker. So we're going to walk you through this journey today to kind of give you a firsthand experience of what this latest technological advance and innovative solution offers your patients or our patients or the community or the world to be able to really revolutionize implant dentistry.
Should be distal test of 9.
Of 9?
Oh, you're almost there.
Distal cusp of 9?
Stay right there.
Perfect. Okay. So that tells us that we're in the right spot. So Alex, turn to your right a little bit. Nope, just like there. Good. Yomi, lateral access on.
Lateral access on.
Hold on. Oh, I have the mouse right here.
Accepted.
Okay, so now we're going to begin to prepare his osteotomy. Al, open big. Good.
Locked in. 1.1.
That's the bigger line.
2. 3. 6. 8.5. Access. Release.
Perfect. Okay, so that's the first osteotomy that I just did. And his tissue is really nice in this area, so I'm probably even going to be able to do this implant flapless. So every burr that I put in, I have to measure and I have to give feedback. So one of the nice things, differences between this generation and the other generation of Yomi, the other one I needed a person standing to be able to put this in. Now with voice activation, I can communicate directly. So Yomi, drill bit 2.2 by 22. Yomi, drill bit 2.2 by 22 millimeters.
2.2 by 22.
And every time I give a command, it gets repeated back to me. Al, open big. Thank you, sir.
Locked in.
So you hear me communicating to me that we're locked in,
9. 9.
and it's calling out.
Access.
The other thing I want you to see is my eyes are on the surgical field. I'm not looking at the screen, which is in some modalities of care, you need to look at the screen to be able to do the surgery as opposed to the patient. Yomi, drill bit 2.8 by 22.
2.8 by 22. Locked in. 1. 2. 3. 7. Access. Released.
Let's go to 3.5. Yomi, drill bit 3.5 by 22.
3.5 by 22. Locked in. 1. 3. 9 point. Access.
So again, I didn't make an incision in this site yet. This is completely flapless, really almost in a way minimally invasive. Let me have the 4.2. Really minimally invasive approach because his tissue is excellent in this area from his healing. We can even see that on the scan because we're able to overlay the soft tissue over the bone in the plan. Yomi, drill bit 4.2 by 22.5. Yomi, drill bit 4.2 by 22.5.
4.2 by 22.5. Locked in.
After this, I'm going to implant, guys.
You're going to implant next?
Can I have a 13? And the implant is about to go in, so the osteotomy is prepared now. And 5 pi by 10, please, confirm. Yomi, baseline. Yomi, drill bit 12 millimeters.
Driver 12.
Yomi, speed 50.
Speed 50.
Yomi,
Guided on 15. Lateral access on.
Yomi, lateral access off.
Lateral access off. Twist left. Locked in.
Okay, here we go. Your implant is about to go in now.
4. 6. 8. And 10.
Free?
Released.
Good. Okay. One of the things I like to do is just to make sure, as accurate as we are, that nothing has really changed. Yomi, osteotomy.
Guided on 15.
Yomi, osteotomy.
Osteotomy.
Yomi, 1.6 by 21 millimeters.
1.6 by 21.
So now we're going to come back and just to make sure nothing has shifted.
Guided on 15.
You're very free.
Yomi, free.
Free.
Follow right there.
Perfect.
Landmark achieved.
Good. So we achieved landmark again, telling me that I haven't moved anything. So we're done.
Pause.
The implant is now in.
So how much pre-planning and work went into this procedure prior to actually working hands-on?
Yeah. So the question is for those that can't hear, how much pre-planning goes into it? And it's always PPP, prior planning pays, right? And whether you're doing freehand or you're doing guided, whatever kind of implant dentistry you're doing, there's always pre-plan that has to occur. On robotic guidance with the Yomi S, there is, you can do a pre-plan. So let's assume, like on Alex, this patient that we saw today, we took out his tooth in September. Okay, I let it heal for a few months. And depending upon your workflow, you can do one of two things, right? So now we've got an extraction socket. You can do a scan the day of, you put that device on and you do the day of scan surgery, and then you can put the implant in on that day, right? And then go ahead and place your implant. So maybe 5 minutes, 10 minutes. Now you might say, well, hold on a second. What happens if I want to take a scan before I do the surgery? So you can take a scan like last week or prior. He comes in to make sure you have enough bone in there, and then you can pre-plan it. So you could take that plan, that DICOM data, put your implant on that, and then your day of surgery scan, marry the two, so you've even lessened the amount of pre-work. So there's options depending upon what works in your workflow for your flexibility. Because let's assume you came in today, you had a fractured number 9, right? I could take care of you today. I could literally scan you today, put the implant today, immediate load today. I don't have to wait to print a guide. I don't have to wait to do all sorts of other modalities of care that are adjunctive to that. Now, when do I take the scan is one that depends upon that person's workflow. Do you take the scan before I take the tooth out? If I'm going to do an immediate extraction, immediate implant placement, I can take the tooth out, then take my X-ray and pre-plan and plan it, or I could take the X-ray, take the tooth out, and do it all that way. For me, I like clean surface. So I would take the tooth out, then take my scan, because sometimes there's gutta percha, sometimes there's amalgam, sometimes there's distortion, and I can't see the buccal plate, or I can't see how thick that buccal plate is with a tooth in place. So I'd like to take the teeth out, get clean surface, then do my scan, and I have my complete viewing of my extraction socket for that immediacy. Does that make sense?
It does.
Yeah.
It does.
So the amount of, you have a lot of flexibility within your workflow, but on a single tooth, for us at this point, and it's really all my team, I'm not even the one that's doing all that. So all this is set up. So I'm being productive elsewhere in the office. So it's to the point now with my team having been doing this for almost 5 to 6 years, we're coming up, that I could literally come in, all planning is done, and just jump right into surgery and then leave and go on to see another patient. So from a scalability and from optimization of time, the workflow is clean. Now, it's taken time. And when people work in this environment, you have to be adaptable. You have to be able to strategize and come up with workflows that are flexible for your office. And that's one of the beautiful things about the Yomi S and the strategic operations that are within it. You can adapt it to your workflow.
Now, with this procedure that you did today, what's the biggest difference that everyone could walk away from you using the Yomi S versus the Yomi?
Okay, so Yomi O, we'll call that was Gen 1, right, versus Yomi S Gen 2. So there are significant differences just in the workflow, all right? So in Yomi O, you need someone to support you from a perspective of, we'll call it a driver, right? You need someone at the computer station to be able to navigate and help you. When you heard me say guided or you heard me say free, it didn't have the voice commands like it does. So I can be autonomous without someone at that computer station. It has, it's so voice. The arm, meaning that the arm that is that I'm utilizing, that robotic arm, the degrees of flexibility that I have with Gen 1 versus Gen 2 or O versus S are limitless. Because when I was using O, and I used O for, let's say, better part of 6 years, there'd be certain points where I would get into a position and it wouldn't let me go. I'd go to the limits of the bend or it being too straight. It doesn't happen with me with the S ecosystem because of technological advances in that design. So I can be a lot more creative. I can do a lot more movements. I can be a lot more efficient. So not only that, I can advance through implants on the foot pedal. So if I'm doing 4 implants, I can literally go 19, 21, 23, 26 by advancing on a foot pedal. So it has foot pedal access, it has voice access, there's visual access. There is so much more advances on O versus S for me that it's a game changer in terms of the technology that is
more advances on the S.
On the S.
Okay.
Yeah, on the S is really a much more advanced. It's a smaller footprint. The other thing was on O, everything was left side of patient. So when you did surgery, it was only on the left and it had an extension that came over the patient. On the S, you can go both sides. I can go left, I can go right, I can go further away from the patient. So it didn't have as much working length or field of view that I do now on the S family. So the benefits and the enhancements are enormous from that perspective. If you're a lefty or you're a righty, depending on what side of the patient you want to work on. You saw me operating on the left. I operate on both sides, but there are some people that are not comfortable with that. I always want to stand on the right. So you can put Yomi left or right, S, not O, Yomi S, left or right. You can stand on the left, you stand on the right. I like to be opposite because I think it just works for me in my hand. So if I'm working on the left side of the patient, I'll stand on the left. If I'm working on the right side, I'll go stand on the right side. If I'm doing a full arch, then it depends upon where I want to be and how I want to approach it to get the best access. So the flexibility and the user ability is really enormous compared to O.
Sounds like it.
Yeah, it's a game changer.
How difficult was it to get, adjusted to looking at the screen and working versus looking in the mouth?
So I don't have to look at the screen with robotics, right? I can look in the mouth. So when I'm doing, everything is mouth-based, right? And I'm hearing and I'm feeling. So there's tactile, there's auditory, and there's visual. So on the arm also, which you can't see here, but and it's kind of hard under the lights. When I say Yomi, right, there's this like magenta or purplish color that comes up that I know Yomi is now engaged. On the robotic arm, they even designed that to be right where my hand is. So if I'm here, how do I know that Yomi hears me? I don't have to look up at the screen. I can see it on there's so many visual cues and so many auditory cues that I can stay really hyper-focused in the surgical arena and my eyes never need to leave the patient, which is amazing for me. Yeah, it's really been, again, very different from some of the other modalities of care that are out there on a deliverable, be able to get what you want.
Sure.
You mentioned at the end of the procedure of the patient, the experience minimal swelling. Can you tell us a little bit about the patient experience overall?
Yeah, it's a great question. So the question is, speak a little bit about the patient experience. So when you're looking at haptic guidance, Yomi S workflows, and on Alex, I didn't take a 15 blades, I didn't raise a flap. Anytime you raise tissue on any part of the body, but we're going to talk about the mouth because that's where we're working. When you have the more tissue you raise, the more space you create for swelling to occur. So if I don't raise a flap, I'm going to have literally minimal swelling. Now, does every patient have flapless like Alex did? No, there are certain things that you have to have. You need to have attached tissue, right? Attached tissue around an implant is so critical for the success. So one of the things that we can do also, which is what we did on Alex, is we did an IOS, an STL scan, an IOF of his soft tissue. We overlaid the soft tissue onto where we wanted to put the implant, so I can see how much attached tissue he has before I even go to surgery. So I can tell you if my inkling is going to be flapless or flap. Now, when I make a flap, I can make a minimal exposure, because once Yomi gets me where I need to be, I'm a believer in it. I've used it enough that once I know where I am, you have to trust the system to be able to get me where I am. So I don't need a big flap. If I'm doing, such as if I'm doing stackable guides, or if I'm doing guided surgery, right? How do I know where I am where I am? I need bigger flaps to be able to see, especially in a stack system. Stack system, you need to make bigger flaps, right? So for me, and even if I'm doing leveling a bone, which Yomi S can do, we can do a bone leveling module in the full arch, or and even in a quadrant. The amount of exposure that I need of that tissue is just minimal of where I'm going to be. I don't need to make a large weeping flap. Again, less pain, less swelling, less bruising, better patient experience. So the more that I can minimize my exposure, as long as I can get where I need to visualize and see, it gives the patients a better experience.
Has it been a process getting the speed up to where it is? You were done in 10 minutes or so.
Yeah, that's a great question. So the question, and I often get asked about that. Now, in terms of speed, that's just a normal state. It's not like I don't have a need for speed, right? My need is for predictability, accuracy, and to making sure I get it exactly where I want it. In time, it happens to just, as you get the workflow and as you go through repetitive surgery, you just get better at it, if you would. And people often ask me, well, I want it for speed. And I'm like, no, that's not, whether it takes me 10 minutes or it takes me 15 minutes or it takes me 20 minutes, we're looking to get treatment for a lifetime, right? That's the goal. And it just happens to be, for me, having done as much of it as I can, it's very comfortable for me. But I don't think that necessarily speed or time is an outcome for success, though many of my colleagues, they want to know that. And it certainly doesn't slow me down. It doesn't. It doesn't slow me down. Right.
Well, what would you think the learning curve would be for a new clinician that receives a Yomi for the first time?
So
when would they feel comfortable actually working on a patient?
So the question is, I don't know if the audience can hear, but what is a new clinician that's onboarded, their time to get them up to being comfortable? It takes time. And because when you're an implant surgeon, and let's assume you're a freehand implant surgeon or you're using guides and you're coming into the robotic world, okay? You're used to a certain stance, you're used to a certain gesture that you're going to do to be able to deliver that freehand or with guides. As you adopt robotic guidance, there are certain things that you have to learn, right? How to stand, how to go, how to be, how to approach, how to sit the patient, and you have to be adaptable. Where I see people get into challenges, they're rigid and they're not willing to learn new innovative and new technologies. If you're someone who's adaptable, not rigid, willing to learn new innovative creative solutions, this is for you. If you're like, no, Yomi has to adapt to me, whether it's O or S, is where some of the challenges come into play. But so I think there's a learning curve for both the clinician and for the staff, because the staff is very much involved in this aspect. It starts at the top with the leader, but the staff has to be mutually involved with the whole workflow to make this a seamless, team-based approach. The teaching team at Neosis, they'll onboard the staff, they'll onboard the clinician. There's so much, and then there's courses and everything across the board, and they really make it so that that delta of time is supported from so many different levels: staff, clinician, education, and that's the key to getting people on board quicker as we can. If you're going to do it or acquired education or organic education, right? And I think that your delta to get you quicker is when you can get it acquired from other clinicians or from the Neosis team.
How many procedures have you done with Yomi so far?
Ooh, The question is, how many procedures have I done with Yomi? I don't know. I can tell you there's been over 1,000, almost 1,500 implants that I put in with it. And there was a paper that I wrote a few years ago about an accuracy study, which has been published in the International Journal of Oral Maxillofacial Implants, which really compared, because one of the things for me when I onboarded, and I was like, okay, I understand everyone is saying it's more accurate. It's more accurate than anything that's out there, but let's prove that, right? It's one thing to say it, it's another thing to prove it. So what we did is we took near 300 implants and we did an accuracy study comparing what's in the literature, freehand, guided, augmented freehand, and haptic guidance Yomi. And unequivocally, and we can get you guys that paper, it was the most accurate across the board of all 4 modalities of care, looking at over 300, about 300, 273 implants to be exact. But we're at almost 1,500 implants with Gen 1 Yomi O and Gen 2 Yomi S.
Well, thank you. This has been amazing.
Thank you for coming.
Congratulations, Doctor. Outstanding.
Thank you.
Really impressive.
And you probably teach yourself, right?
We do,
And
yeah.
You offer CE.
We do, yeah. I mean, on multitude of levels, whether it's, implant dentistry with robotics, then there's the whole other world in the digital space, because that's even another aspect where really Yomi seamlessly interdigitates with the digital workflow of dual arch scanning, of really prosthetically positioning implants on the full arch and doing an iOS and doing a dual scan and integrating with photogrammetry and integrating with, whether it's milling or printing. These are all aspects that Yomi seamlessly integrates with on the digital platform. How you feel?
Good.
Any pain?
No, just numb.
So you went through an extraction back in September, and now you went through the implant. Give us a little bit of what the extraction was like and what the implant was like.
I mean, the extraction, not that it was like awful, but it was significantly more painful, more uncomfortable. The most uncomfortable part of it was having to open my mouth so wide. Other than that, like, just a little bit of vibration. Honestly, hearing you give the commands was kind of was pretty cool, and like how it responded. So I was like more like engaged with like what you were going to say next and like the measurements and stuff. I wasn't uncomfortable at all. And I've had root canals done. That was awful compared to this. I mean, it's unrecognizable as far as like the pain level, the uncomfortable level. That was like a walk in the park, whereas the root canal, I feel like I'm running a marathon, pain-wise.
Okay.
Was this your first implant?
Yes, ever.
How did you find Dr. J?
He's my uncle.
I don't. This is my nephew.
Oh, okay.
What's that? No, I need it up here.
So, I mean, I think the biggest question is, from a patient perspective, were you reluctant or hesitant to have a robot perform this surgery on you?
I would be lying to you if I wasn't a little hesitant. I just because, like, I don't know, like if the robot does something and it's just kind of like does whatever it wants. We've all seen the movies where like the robot takes control and does whatever it wants, but he was in control of the robot. So I wasn't nervous that there was going to be any pain or anything like that. I was just more like anxious to see like how it was going to actually be involved in the surgery. Like I didn't know what it was going to do. I thought it was going to be cutting or slicing or something, and the fact that it was just popping in little holes like that, it kind of blew me away when I was sitting there. I just wasn't expecting that, so it was cool.
I guess you were surprised at how quick the procedure was.
Yeah, the prep was 3 times as long as the actual surgery. So I mean, that was. I mean, I thought it was going to be like an hour surgery or a half-hour surgery at least, and for it to be, what was that, 10 minutes maybe? I mean, that was.
Roughly. I didn't time it, but it seemed impossibly quick.
Yeah, and for me to be sitting here talking after all that, I mean, no pain. I mean, it's just a little bit of pressure. I think the best description I could give is just pressure here, but not anything that is, like a high pain scale or anything like that. Is very, very manageable.
So when's your next one?
I'm trying to keep my teeth in my mouth for as long as I can. But at least I know if I do lose it, I know where to
I
go.
think one of the perceptions of, kind of R2D2 coming in here and placing the implant is one, with robotics, right, is one that I think is real. I think that a lot of patients think, oh my God, it's going to be an autonomous, like you're just going to sit back, but that's not the case at all. It's more of, if you look at the X-ray, this is the post-op X-ray. So it's more to me of just about managing space, right? But I'm doing the surgery, and I equate this to kind of being on a railroad car, right? So you're on this locomotive, and I'm the conductor, right? And I'm going forward and back on the power for it, and I always have the ability to, if I have to abort and get out, there are safety ways for me to abort and get out. In case that doomsday that he's talking about happens, which in my career has not happened in all the surgeries that I've done. I've not had to have that doomsday pulled. But the ability to navigate to a place and a space and exactly where I want to put that implant predictably, accurately, with minimal invasive in the time that we do, I mean, it makes something that seems somewhat daunting really straightforward and predictable, where he could be playing golf tomorrow and is probably not even going to have any soreness or pain from this. Minimal downtime, minimal intrusiveness in his life, and really, changing his life for him for a period of time. Other questions?
Any other questions? I mean, I have a question for you
Sure.
in front of the patient.
You can ask me.
From a billing standpoint,
Yeah.
for the same type of implant,
Yep.
but if you would have done it by hand versus using a robot,
For sure.
what would you increase or charge? You would obviously structure your pricing different.
Yeah. So I get that question asked a lot. Okay. But I place every implant robotically. So you get me. So when I take care of patients, I take care of patients like I'm taking care of my mother. So what I would do to him, or what I would do to him, or what I would do to you, I'm going to take care of you the same. I don't go one from column A, one from column B. Now, there are clinicians out there that do that. In my workflow, in my practice, I don't want to do that. I want to treat everyone the same. I don't have, if I'm going to do it robotically, I'm charging X, and if I'm doing it not robotically. I think it creates blurriness, and I think that when a patient comes to a clinician, they trust you, and they want you to treat you like the highest level. I mean, the first person who got an implant placed on the Yomi S was my mother, literally. Wow. In the world, ever put in a live human, was literally my mother. And if it's good enough for that, then it's good enough for anybody. And I'm not going to create different price segments. And I get asked that all the time. I mean, people come to me and they say, from a management perspective, how do you handle that? There's even so much that people will use a premium implant and a non-premium implant to a patient. So imagine he comes to me, and I'm going to put an implant in him, and I say, okay, and the coordinator comes in and says, okay, well, I can have implant brand A, I could have implant brand B, I could have it placed by a Yomi S, or I could have it placed freehand. They're like, what? I mean, you want to talk about chaos. You want to talk about confusion. I mean, they're in your office, they trust you. Like, no, treat the patient how you'd want to be treated yourself. If you're going to change fees, then just charge one fee and figure out a workflow that works for their patient, because you're going to have people walking out just so confused, and it's stressful enough. I lecture to dentists all the time, and one of the first questions that I ask them is, how many people like going to the dentist? Now, these are dentists. How many people like going to the dentist themselves? Nobody raises their hands, right? So why, as we as clinicians, make it more difficult or create more confusion when you don't even like going, and now you have someone who's sitting in your chair, nervous, tight, apprehensive. The last place they want to be is here, and you're going to ask them to take one from column A or one from column B? Yeah, that does not work for me. It really doesn't. I mean, I want to demystify, simplify, and just put my arm around a patient who's so nervous and just make it better for them. So I don't charge, like I said, so every implant that I place is placed robotically. I do not place implants freehand anymore. Unless there's some major catastrophe that I have that for some reason, there's an outlying situation, it more on the patient side than it is on any other aspect. I mean, in the last 6 years, I don't think it's very, 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 very rare. If I have to go to the hospital and I have to take care of a patient there, I don't have Yomi S there. That's where I would go in the freehand space. But in my office, they're all done with Yomi S.
Makes sense. So at what point will you have your patient come back?
In a week to do a post-op check. And then I'll see them at around 3 months and we'll take an x-ray, see how it looks. And then if at that point we like what we see, then they'll go back to the restorative dentist and have their implant supported crown fabricated.
And what questions did you have coming here today about the Yomi device?
Well, I wanted to obviously know like what it looked like, what it did, and all like the ways that he could manipulate things. I've talked to him about it very, very briefly, and my dental degree is also lacking, so I don't know exactly what he's saying half the time. But he was just kind of telling me, all these cool things that he can do with it, and how it's going to revolutionize, the dental field and how implants are put in today. And I was just, very excited to come and not only see it, but also experience it. And I mean, blown away, expectations blown away. I just didn't anticipate it being that fast, that painless. And for him to be able to communicate seamlessly like that with it, I thought was very, very cool.